I was asked to speak on navigation technology, current state of the art and future state of the art, and I have a few disclosures to discuss. I do consult for Globus, particularly in robotics navigation, so that is a relevant disclosure here that you all should be aware of. And another disclosure would be that while I have done some navigation in isolation, most of my navigation is in conjunction with robotics. So what is navigation in spine surgery? It's utilizing usually intraoperative CT, but can be preoperative CT for placement of pedicle screws. There are some other applications of navigation whereby you can check anatomy. It facilitates minimally invasive surgery. So I think the major reason that people want to use navigation is to increase screw accuracy and decrease radiation. But that is a little bit of a catch-22 because while it might decrease radiation for the surgeon who's not in the room during an intraoperative scan, it may increase radiation to the patient. If you're not someone that tends to get preoperative CT scans, you're probably going to be getting more preoperative CT scans on your patients when you're going to use navigation. But for many people, that is a standard of care anyway. And so in some cases, in the majority of cases, I would say, this may not necessarily be an increased dose of radiation to the patient. There are platforms that utilize 2D navigation. So you just shoot some fluoro shots and then navigate the instruments thereafter. And that would actually potentially decrease radiation to the patient as well as to the entire surgical team. So there are those advantages. And those are the primary reasons that I think navigation is utilized. So what are the surgeries that it's very applicable in? Posterior decompression. So you can, if you're doing it percutaneously in particular, you can stick a probe down that's navigated, check out the anatomy, understand it in 3 dimensions, look to see if you've done an adequate 3-dimensional decompression of the lateral recess of the foramen. So that's an important application. Placement of the percutaneous screws, as I mentioned. Minimally invasive transfemoral interbody fusions, lateral interbody fusions. Imagine not having to take a million fluoro shots to see where your dilator is going, and then whether you've entered the disc, whether you've gone completely across the disc with the cage, with the cob, with preparation of the end plate. And then, as I mentioned, most of the navigation is CT guided with preoperative CTs that are then registered with intraoperative fluoroscopy or intraoperative CTs that then you take off with navigation. And now, more recently, there's integration of robotics and navigation together. So here's some studies that have brought attention to navigation, and these are quite early. You can see this is a study from 2010 where they did a meta-analysis. They combined 28 cervical studies, 24 thoracic, 24 lumbar, and they found indeed that there was a decreased amount of radiation and dosage with CT navigation, increased accuracy trend for pedicle screw placement. Then moving on down the road, each of these meta-analyses added more and more studies to their cohort, 26 studies, and you can see the evaluation of accuracy, freehand, 89 to 94, freehand with fluoro wasn't so great in some studies. Fluoro with nav, the accuracy increased 81 to 92 relative to the freehand with fluoro, but CTNAV with accuracy was pretty good, 89 to 100%. So there's a variability between different studies. But I also think that there's potential applications in adult spinal deformity because you have rotational deformities that can be complex. Frequently, we're revising those screws if the deformity is very severe, the pedicles are very small. So it might help with accuracy of those screw placements. It can help with placing iliac screws effectively. Frequently, people are doing S2AI techniques utilizing fluoroscopy, now that you can take the fluoroscopy out of the equation and use navigation instead. And of course, minimally invasive deformities like this can also facilitate the pedicle screw placement as well as the iliac screw placement. And I think in open cases, you can also do percutaneous screws at the very top of the construct, something that's been written about. It's been theorized to decrease the rate of PJK, PJF. This type of application, I think, is a no-brainer because it'll help facilitate placement of that screw without extensive soft tissue dissection. So here's another meta-analysis moving to 2013 of 52 studies, and it did show that the pedicle screw accuracy was higher in the navigated CT So you can see there 98.8% versus 79. There were fewer neuromonitoring changes in the CTNAV study, CTNAV arms, and less radiation. Another one from 2014, a review of 30 studies, increased pedicle screw accuracy, decreased neurologic injury, 94% accurate lumbar pedicle screw placements with CTNAV, and the breach rate was 6% versus 15% in freehand. And they concluded also that your accuracy is worse the farther away you are from your fiducial marker. So the question is cost as well. You just heard from Dr. Hostin about it. These are expensive technology platforms. And this study particularly estimated that you need to do at least 150 cases per year in order to become cost effective. I've heard various numbers depending on who's touting the technology. So that's something that would also need to be looked at very carefully. But it seems like it's going to be the wave of the future, some amount of integration. Here's a study that looked at, again, a review of the literature, 2,000 patients, over 2,000 patients, over 13,000 pedicle screws, 0.4% navigated pedicle screws were revised versus 1.1 in freehand pedicle screws. This is actually a randomized trial where they randomized patients to NAV versus conventional techniques. There was a percutaneous cohort and there was an open cohort. In the open cohort, there was a less screw malposition rate in NAV, 5% versus 17, which is actually a very high rate. There was more radiation exposure in the NAV group. You can see that it's 0.21 versus 0.1, so double the radiation dose. And there was a longer screw insertion time when you utilize NAV. So the question is whether that's optimal. There's a trade-off between time, radiation exposure, but screw malposition, and whether those are actually clinically relevant. The PERC group, a little bit of a better argument, higher malposition rate in the 24% versus 5%. So you're kind of flipping the paradigm a little bit. There's less radiation exposure though. If you use NAV, it was 0.6 versus 1.62, so almost 3 times less radiation. But the screw insertion time was also longer. So in both cases, NAV slows you down, according to that study. Here's a case of mine, a 60-year-old female. She had severe back pain, bilateral thigh pain. You can see she's got a significant curl deformity, a mild sagittal deformity, a little bit of a lumbar lordosis mismatch relative to her PI. And I did utilize intraoperative CT guided navigation to place these screws. And I think there's advantages here with the rotational deformity, placement of the screws accurately. We didn't have to revise any of these screws. And then also for the deformity correction, you can run a scan like this at the end of the case and really find out if you've actually met your sagittal alignment goals and measure the parameters that you think are the most important. So I think in some cases these are very effective, but there is a trade-off of time, and I think overall I'm much faster when I'm not utilizing navigation and deformities. You can see her 1-year post-op. She does have a leg length discrepancy with the shoe lift. She's nice and straight. Pre-op to post-op. So in summary, and what's coming down the pike, I think there's a good argument for our screw accuracy utilizing navigation. I think that there are some no-brainer applications, particularly in minimally invasive surgery. Also, down the road, at some point, integrating with preoperative surgical plans, with preoperative surgical planning platforms, intraoperative confirmation of those measurements, showing that you've met your goals to have optimal outcomes. Navigated burrs to do laminectomies. Imagine taking a 3-dimensional axial and kind of highlighting out all the parts that you're going to remove, and then being able to do that, utilizing maybe an integration with a robotic arm. So augmentation with augmented reality, artificial intelligence, navigation, robotics, all integrated into one platform, and then layering in the safety and quality and cost that you heard about from our previous speakers, Dr. Hassan and Dr. Ames. So I think that's the end there. So if there's any questions, I'd be happy to take them. Otherwise, well done.